In this lecture, you will learn about insulin, how insulin acts, and the pharmacotherapy of type 1 diabetes mellitus. If we start is what insulin is, insulin is a peptide hormone secreted from the beta cells of the pancreas, and it regulates blood glucose level by increasing the cellular uptake of glucose from adipose tissue and the muscle, also by regulating the carbohydrate, protein, and lipid metabolism. Insulin initiates its an action by binding to a glycoprotein receptor on the surface of the cell. So this receptor consists of two subunits, the alpha subunit which binds to the insulin and the beta subunit which is insulin stimulated tyrosine specific protein kinase. Looking at the pharmacotherapy of type 1 diabetes mellitus, all patients with type 1 DM they require insulin. So insulin have different types and we have different regimens available. These insulin they differ in their onset of action and also in their duration of action. Mainly, we have two types of insulin: the basal insulin and the prandial insulin. The basal insulin is the insulin that works steadily throughout the day, and this one it has slow onset of action and long duration of action. But the prandial insulin it is the mealtime insulin, so the patient can take before the immediately before the meal, and this insulin type it has a short duration of action and very and fast onset. And the therapy should attempt to match the patient's carbohydrate intake with insulin and also the non-pharmacological treatment, which is the exercise. So it is important to know that because insulin is a polypeptide hormone, it will be degraded in the gastrointestinal tract if it is taken orally. That is why it is always given subcutaneously. But in emergency situations, regular insulin can be given intravenously. There are four types of insulin available in the market: the short-acting ones, the rapid-acting ones, the intermediate-acting ones, and the long-acting ones. The short-acting insulin is the regular insulin. This insulin it has a slow onset of action and it should be given 30 minutes before the meals. While the rapid-acting insulins are the lispro, aspart, and glulisine. These ones they are more convenient because they can be taken only 10 minutes before the meals. The intermediate acting insulin is called the NPH, neutral protamine hydrochrome, and this one it can be prepared by the patient and it has a variability in absorption. That's why it can lead to nocturnal hypoglycemia. And the last one I had the long-acting insulins, and these ones are the glargine and detimel. These ones they are long-acting, peakless human insulin, and they don't have they will not go to the nocturnal hypoglycemia of the intermediate like the intermediate acting insulin. For the dose of insulin, patients may be started with 0.6 unit per kg daily, and this dose can be divided into two daily insulin injections so that it can resemble the physiological release of insulin. And in the morning, it can be given like intermediate acting insulin like NPH plus regular insulin, which is short acting before the breakfast. And again in the evening it can be given the same like intermediate acting insulin plus the regular insulin. And for the dose, 2/3 of the dose should be given in the morning, and while 1/3 of the dose will be given in the evening. This is called the basal bolus concept, and this concept it tries to resemble the normal physiologic secretion of insulin by giving the basal like intermediate or long acting insulin as the basal and giving short or rapid acting as the bolus dose. And the intermediate acting, like the basal one, it can be two times of intermediate acting insulin like NPH, or also insulin itimer, or once daily insulin glargine, while the bolus will be like rapid acting or short acting before the meals. Pramlintide, which is an amylin analog, can be given to patients who have still a high postprandial glucose level despite applying all the other strategies. So, at the initiation of the pramlintide, prandial glucose can be reduced by 30 to 50% to avoid hypoglycemia. Hypoglycemia and weight gain are the most side effects of insulin, and it can be managed by giving either 10 grams of glucose for conscious patients, or IV dextrose for unconscious patients, or glucagon intramuscularly when the IV access will not be found.